Good morning, everyone. I'm really delighted to welcome you to our COVID-19 community practice for family doctors. I'm Dr. Tara Kiran. I'm going to be your host today, your moderator. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. We're really delighted at the University of Toronto to partner with the OCFP on hosting these events, and I'm going to turn it over to my colleague, Liz Muggah, the president of the OCFP.
Thanks, Tara. So good morning, everyone. We are really excited about our panel today. Two incredible guests who are joining us as well, of course, as David, Tara, and myself. This is an accredited program. Details are there, and they'll be emailed to you about your main pro credits. Next slide. So this is our land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from Ottawa, Algonquin, and Anishinaabe territory. Over to you, Tara.
So I just wanted to share a great resource developed by the Women's College Hospital COVID equity team. I was sent this resource by Dr. Vanessa Reddit. I know her team, Lisa Richardson and others contributed to creating them. And they're a great resource because for people going in and doing work in pop-up clinics in marginalized communities, we know that part of the equity strategy in improving vaccination rates in our province and the equity around vaccination is doing these pop-up clinics, but often it means interacting with marginalized communities that have historically not had good interactions with the medical community. And so by situating ourselves in that, understanding kind of where we're at, and then educating ourselves, part of that is how we can prepare for moving forward. And so I really will circulate these afterwards for any of you who are going to be going to pop-up clinics because it's a great tool. Next slide. So we've, this is now over a year since we've been doing these sessions where we're learning and sharing from each other as family doctors. I think this is the first time that we've actually had two specialists join, but I think it really speaks to the depth of knowledge that is kind of required in the changing guidance. And I know so many of you are looking forward to hearing from our specialist colleagues today so that we can strengthen the work we're doing as family doctors. Next slide. I just a shout out to our planning committee, and we choose the speakers, but we definitely take your recommendations to heart. So fill out those evaluations at the end and tell us what you want to hear about and who you want to hear it from. Next slide. So I'm delighted to welcome our panelists today, and I'm going to turn it over to them one by one to introduce themselves. Next slide. Menaka, do you want to go ahead?
Yeah, absolutely. Hi, everyone. I'm Dr. Menaka Pai. I'm a hematologist and thrombosis physician at McMaster University. And apart from an honorarium from the OCFP, I have no conflicts of interest to declare.
Allison?
Sorry, I'm Allison McGeer, and I'm an I have to say, I kind of think everybody's an infectious disease specialist these days. I don't feel special or different in any way. So I'm not sure there's any differentiation anymore. Anyhow, I do a lot of work with COVID vaccines and other infectious diseases, and you can see I have grant support and honoraria from ad boards from a number of the companies that are working on drugs and vaccines for COVID.
David?
Thanks, Tara. I'm David Kaplan. I'm a family doctor in North York and the Chief of Clinical Quality at Ontario Health. I receive salary support from Ontario Health and an honoraria from the Ontario College.
Liz?
Yeah, I'm Liz Muggah. I'm a family doctor from Ottawa, and I'm the president of the Ontario College of Family Physicians, and I receive a stipend from them for this role.
And as mentioned, I'm Tara Kiran, family doctor at St. Mike's, and I am a researcher, have a number of grants and salary support that I receive as well, and I've listed the institutions I receive them from there. The only for-profit company is Gilead Sciences, and that was for a grant for Hep C. Next slide. We're, of course, really excited that all of you can join us from all over Ontario with so much diverse expertise. And when you register for the session, you share with us your questions. Next slide. So we designed this session really based on what we hear from you. And these are the topics that we're absolutely going to cover today. So we're going to give you the latest on VIIT. So, that was the same thing that was VIPIT, now VIIT. And Mrna Pai is going to give us the lowdown on that, what we need to look out for. There was the new, guidance released from NASTY, new recommendations. So we're going to talk about that and how we can, as family doctors, can counsel about that. We're going to do a deeper dive into the vaccines and variants, thanks to Allison McGeer, and she's also going to take us through some of pieces around J&J. And David Kaplan is going to give us a bit of an update on where we're at with primary care actually delivering the vaccines. We know that this is our shot. It's our shot to, get us to the end. We're near the home stretch, fingers crossed. At the same time, we know all of you have been working really hard, and it's been a tough month, a tough week. And it's tough to see what's going on in our backyard, but also around the world. And we know that and are keeping that in mind. And hopefully we're giving you tools that will help you on your journey. And thank you for all you're doing. Next slide. So I think all of you are probably quite aware of how this works, but in case this is your first session, please do put your questions into the Q&A. That's how we prioritize what we ask our panelists. So use the thumbs up if you see a question there, because the things that are at the thumbs up are the things that the things that are at the top, do the thumbs up, are the things I'm going to ask our panelists. Please do look at the answered questions as well, because I know our panelists like Allison McGeer do a great job answering through typing a lot of the questions there, and we'll try our best to summarize those afterwards and circulate that as well. And then if you want to share resources or connect with others, please do use the chat. Don't put your questions in the chat, but please do share resources, thoughts, etc. In the chat. Next slide. So I'm going to turn it over to our first panelist, Menaka. And Menaka, I'm wondering if you could tell us the latest on VIIT and kind of how we should be approaching counseling around AstraZeneca and soon, I guess, J&J.
Thank you so much. So Brian, next slide, please. Let's jump right into it. So VIIT or VITT, so the latest is, we've actually changed the name again. I'm sorry, Tara, but this condition is vaccine-induced immune thrombotic thrombocytopenia. And what I will start by saying is, I know I'm not an infectious disease specialist. My expertise is in blood clots. So my goal is to really give you my take on this as a hematologist. And I think I'm going to learn a lot from you all as well, because though this is a rare hematologic adverse event, it has massive implications for really, I think, every part of our vaccine rollout. So I'm going to call this VIIT, just for efficiency's sake this morning. So VIIT is a newly described syndrome. 8 weeks ago, we did not know that this existed. And it has 3 key features that I really want you to remember. So first, patients have blood clots, generally in unusual sites, like the cerebral veins or the portal circulation, but they can actually appear anywhere. So you can see heart attacks, strokes, acute limb ischemia, garden variety DVTs, and PEs. They also have low platelets, usually quite significant. So we know that the range in reported cases is between 10 and 110, but the median is 20 to 30. So this is a pretty unmissable thrombocytopenia. And then finally, there's a very typical time frame. So the symptoms of VIIT, their onset is between 4 and 28 days after you get a vaccination with any of the adenoviral vector COVID-19 vaccines. Now, interestingly, the patients who are affected are generally healthy before presentation. So there's really no signal that they had any pre-existing disease. But even if they were in good health before, up to 40% of the early reported cases actually passed away. You've probably seen incidence figures all over the place. So I'm going to tell you what I believe to be true and what I think most scientists believe to be true. We believe that the incidence with AZ Covishield of VIIT is between 1 in 30,000. That's kind of the low end from the Nordic countries, which have very reliable surveillance, up to 1 in 100,000 doses. And that data is from the UK, which has the largest number of cases. Allison's going to be talking about the Jansen virus. We think the incidence is about 1 in 500,000 doses. That's all from the US, and they're still accruing cases. Initially, we thought women were more affected, but that was probably a selection bias because we were rolling out these adenoviral vaccines to women first. What we now believe is that there's only a slight predominance of women, and that the risk is probably stable across all age ranges. Now, as I mentioned, there's no really clear signal about risk factors. So whether your patient has had previous clots or a family history of clots or autoimmune disease, whether they're on estrogen-containing hormones, if they're pregnant, really no evidence that any of that would predispose them to getting VIIT. Now, the very busy image on the right of your screen is not a diagram of VIIT. It's like too new. We don't even have a diagram of it yet, but it's a diagram of a highly analogous condition, which is heparin-induced thrombocytopenia, or HIT. So in HIT, patients who receive heparin develop antibodies to a complex of heparin and platelet factor 4, which actually sits on the surface of the platelets. These antibodies, they activate the platelets. So they cause a coagulation storm that leads to clotting in any arterial or venous territory. They also clear out the platelets via Fc receptors. So what happens is you have a thrombocytopenia. So you can see the analogy here between HIT, a disease we know about, which occurs 4 to 28 days after heparin administration, and VIIT, which has nothing to do with heparin, but has essentially the same antibodies and occurs 4 to 28 days after adenoviral vector vaccination for COVID-19. So we can go to the next slide. I'm really proud of this algorithm, and I'll tell you why. So this comes from the Ontario COVID-19 Science Advisory Table. It's a real honor for me as a hematologist to be on this table. But the real reason I'm proud of this algorithm, which is going to be updated, we hope in a matter of hours. Some of you may have seen the old link, which is still pretty valid too. It's because it was a multidisciplinary labor of love. So I see some friends in this participant list, including Alan Grill. We have Kate Miller, who's a rural family doc, Yolanda Neal, who's an urban family doc. We have Noah Ivers from Women's College. Folks like you have contributed to this to really get an algorithm that I think works on the front lines, because that's the whole point of this messaging. So this walks you through very quickly the diagnosis and treatment of VIIT. It gives you the laundry list of symptoms that should raise the radar for you that this might be happening. All of them are symptoms that suggest either clotting or bleeding. It reminds you about that really key time frame. If these symptoms occurred outside of that window, it's very unlikely that you're dealing with a VIIT case. And then it tells you what you need to do as a primary care physician, which is order a CBC. So the thrombocytopenia, that's like the third T, that is actually has a very good negative predictive value for telling you whether you're dealing with VIIT or not. So if your platelet count is greater than 150, you should work up the symptoms for other causes. But if it's less than 150, you should really be aware of VIIT. I'm not going to get into the treatment too much because we're suggesting that treatment actually occur in an emergency department setting because this is a very serious clotting issue. But I hope that this algorithm will help you triage patients efficiently and safely. And we actually have a one-pager just for family physicians, which is coming out later today as well. My goal is just increasing patient and provider awareness of symptoms. We don't want to burden the system. We know this is rare and we don't want to miss cases. We know that there's over 600,000 AstraZeneca doses that have been given in Ontario, and that means there is an existing risk of these aggressive and challenging clots. So early recognition is key. Next slide. Thank you. Okay, this is the densest slide ever. I'm going to speak to it very briefly. So we all heard the NACI statement on Monday, and I think it caused quite a bit of pandemonium, certainly among my patients and maybe among yours as well. So I'm going to tell you my take on this as a non-infectious disease specialist. So one of the most, I think, controversial parts about NACI's communication was that they called the mRNA vaccines preferential. The reason they did that was because of the VIIT issue. So I've told you that there's an incidence of 30 to 100,000 with AstraZeneca. The incidence of VIIT with the mRNA vaccines, we believe, is 0. And that's the reason for that statement. But how do we then action the rest of their statement? How do we make that real to our patients? What I'm doing, and what I'm sure you are all doing, is explicitly working through a benefit risk analysis. So we have really, at least in the thrombosis world, moved away from the messaging of take the first vaccine that's available to you. That is a great message. And it was very relevant when we didn't have a lot of choice around our vaccines and when the pandemic was really raging. It's still raging, but it's not raging equally for everybody. So what I'm talking to my patients about is I'm being transparent with them about the risk of VIIT. I'm informing them of the symptoms, so we all recognize it. And then I'm explicitly walking through a risk-benefit analysis. So I'm telling them that they should get the first vaccine available to them if they live in an area where the force of infection is high. So there's a lot of virus in the community. They should take the first vaccine available to them if, because of life or work, they can't protect themselves from exposures outside their home. And they should take the first vaccine available to them if, with all of that going on, their risk with COVID of complications is really serious. So patients with comorbidities, patients who are older, we know that they're filling our ICUs. If they can wait for an mRNA vaccine, then they can safely do that. But we also need to think about the delay in getting an mRNA vaccine. So that's part of the risk-benefit analysis. Next slide, please, Brian. And this is my final slide. I know we have time for questions and also, of course, for Allison. As I said, I'm shifting away from that first vaccine available message. I'm trying to give people more nuance. I'm trying to inform them about VIIT without scaring the pants off of them, really just trying to be focused on shared decision making. There are lots of ways to do that. I'm aware that I'm talking to really a group of experts who do shared decision making every day with their patients. But I did want to cite this one decision support tool I have found really helpful and accurate. This is from Pharmacy 5 and 5. Noah Ivers also was involved in the development of this tool from a family physician perspective. Basically, the slide here shows how the vaccines stack up. You see that the big difference is actually in VIIT risk, not really in too much else. And it also shows on the second part that the risk of it is stable across age groups, but the benefits of the AstraZeneca vaccine are also a little different across age groups because the COVID risk is different. So this is just one of many tools that are available. I think at the end of the day, it's our relationship with the patient in front of us that matters the most. But I hope that this helps sort of add some background, give you the hematology standpoint, and empower you to continue making good decisions with your patients. And that's all I've got, Tara. I'm happy to take questions and listen to Allison's talk as well.
Thanks so much, Menaka. And there are lots of questions, so we're certainly going to be getting to that. I think I just wanted to also add my own take on kind of how I've been approaching the counseling as well. Next slide. When I went through the NACI decision, I went through it in detail to take a look at. They've got a whole bunch of tables actually at the back of their document, and the table kind of goes through, what is the risk and benefit in terms of the risk of, for example, of ICU admission due to COVID versus the risk of ICU admission due to VIIT, and they note, for what age group and what risk level of COVID circulating does the benefit outweigh the risk. And so if you go to that back page, you'll see that the benefit outweighs the risk pretty much for anyone who is 40 and over, and for anyone who's living in a community with a medium or high, or what they term very high risk or circulating COVID. And I put this graph up from How's My Flattening, or this infograph from How's My Flattening, because it illustrates that across Ontario, the community risk is variable. There are certainly lots of regions, and the GTA there lights up, but so do some other areas in the southern and northern parts of Ontario, where it's really clearly high community risk because of large amounts of circulating COVID. And so when you're in a place with high community risk or medium community risk, and you have a patient in front of you who's 40 and over, and that's actually only who's eligible in Ontario anyway, to me, the risk, the benefit of AstraZeneca outweighs the risk, especially given that for many people, it's a month or more until they are able to often get that appointment through the provincial booking system. So that obviously is a huge factor as well. So if they're able to walk into a pop-up clinic and get the mRNA, okay, great. But many patients can't, but they can walk into a pharmacy, or they can come to our office in select cases, and we're going to talk about who can do that. So that's sort of my take on how I've been interpreting NACI's guidance and counseling. I know so many of you guys have questions about what Menaka has said. And so I'm going to just ask a couple. So the first one, I guess, is, what should we do about that second dose, Menaka? So somebody's gotten the first dose of AstraZeneca. Is there the same risk of VITT for that second dose? And should they be getting them the second dose as AstraZeneca? Will we even have AstraZeneca? I mean, you might not be able to answer that. Or can we mix and match? And this might be a question for both you, Menaka, and for Allison.
Yeah, I can tackle the risk issue. So what we know from the UK is that there have been 4 reported cases now, credible cases of VIIT, when the first dose was unremarkable and the second dose triggered it. So we're still learning more. My hunch is that the risk is rarer. However, because this is all rare and new, I'm telling people to monitor for symptoms for the first 4 to 28 days, regardless of whether it's the first or second dose.
Tara, you're muted.
Sorry. Allison, I wonder if you could comment on whether people will be getting an mRNA booster, for example, if they got AstraZeneca as the first dose. So that's a common question that we're hearing from our patients, and that folks asked, and I think you might have answered already in the chat, in the Q&A as well.
Yeah, and it's really difficult. We're waiting to see the immunogenicity studies from a couple of mix and match studies in the UK, and I think Alan's just put the link to those studies in the chat box for people to look at. It is very likely that your response to a mixed vaccine schedule will be fine. We don't usually mix vaccine schedules, but we do it when we have shortages on a moderately routine basis, and so we're likely going to do that. People don't want to make a decision that they're going to have to reverse, right? We've done that so often. We really don't want to do that. But the price of doing that is making all those people who've had 1 dose of AstraZeneca sit waiting until we have more data and can make sort of the best decision for each one of those people. So my guess is we're going to mix and match, and we will switch people who had AstraZeneca to Pfizer, but it really depends on what the data gives us in the next few weeks about what the best option for those people is.
Yeah, and so I think the similar question is, so I think there are many patients as well as many physicians who are worried, we may not get AstraZeneca supply for the second dose, especially given what's happening in India, and that a lot of our supply was Covishield. I don't know if anybody has any comments on whether that, may come to play. Obviously hard to predict the future, but it sounds like, Allison, what you're saying is in that scenario, there's a likelihood that we will be moving to mix and matching, although we don't know at this time.
We've never not been able to mix vaccines when we needed to. So I don't want to say never, okay? This is a new virus, and we need to have as much information as we can about decisions, but anytime we've had to mix vaccines before, it's always been fine. So there's a long list of things that are keeping me up at night. And one of them is how worried people are who've had their first dose about what's going to happen. I get that. What I'm not worried about is the fact that we'll find a solution for them. Okay, we will be okay. It's just I feel really badly about the stress that it's causing for people.
Great. Yeah. No. Thank you, Menaka. So a question for you. You said GP should order CBC, but we don't get the results until the next day. Do we actually need to send people to the emergency department to get that CBC?
Yeah, that is a great question. So let me give you a bit of background. So I'm a hematologist at an academic center, but I'm the only person of that phenotype on this science brief and the guidance, which I'm happy to share with all of you. we had to create something that was one size fits all across the province that would work even for remote centers, rural centers. I fully appreciate the challenges in getting fast turnaround times from local labs. I experience it too. If this is something that is urgent enough, and we actually put this in the text of our brief, that if you don't think you can get a CBC in 6 to 12 hours for non-severe symptoms, then please send to the eMERGE. And our eMERGE colleagues agree. And if symptoms are severe, like for example, a terrible splitting headache with diplopia, please send to the eMERGE. That's actually explicit in our guidance. And somebody's asked about treatment options for eMERGE physicians. We have an entirely separate brief guide for them too. Again, happy to share all of this because we understand the diversity of practice and the challenges on the ground.
Another question for you, Menaka. Adriana asked, VIIT has a still quite high fatality rate, up to 40%. Why is this the case? Is it just that we don't recognize these cases early enough, or is in some cases we simply can't do much? It seems awfully high.
Yeah, it's actually both. And that's why I love this question. I hate the comparisons between the VIIT clots to other clots, right? Whether it's birth control pills or even COVID, these are very different clots. So there's two aspects for it. One, the type of clots are pretty weird. It's really hard to diagnose CSVT and portal vein thrombosis. And like, I'm a thrombosis doctor and I find those symptoms like kind of vague and confusing. So definitely cases do worse if they're not detected. We're seeing that again and again. The other thing is the physiology of these clots. They are so aggressive. So you have low platelets, and remember, they've switched on all over the body. So you have like a little clotting storm in every vascular bed. And it's not just anticoagulation, you need immunosuppression, like it's all hands on deck. And if there's even a little delay in treatment or the antibodies are very aggressive, we lose the battle. So I don't want to reassure people that if they walk in, we can easily fix this. This is a clot that scares people like me.
Thanks, Menaka. Allison, I'm going to go to a couple of questions for you. So Allison, I think one of our top asked questions is, when should those of us who got our mRNA vaccine early and are now close to 6 months need a booster dose? Oh, you're just on mute, Allison.
I mute myself, yeah. I actually can't believe it's 6 months already and we're getting close to worrying about it. So I think the answer is that the vaccine is likely to protect us very well for longer than 6 months, okay? The 6 months is not the vaccine protects you for 6 months. It's actually, the vaccine protects you for at least 6 months. Because remember, we only have 6 months of published data, right? It's not that vaccine starts to fade after 6 months. It's that we don't know what happens after 6 months. And in another couple of months, we will know what happens after 6 months. I think there might already be a Moderna paper, I'm losing track out, about an extension to 9 months, which looks fine. So the first thing is, I don't really think we need to be worrying about 6 months, but there are both Pfizer and Moderna have phase 1 trials going on. The Moderna trial results just came out looking at vaccines that have B351 in them, as well as the old Wuhan strain. So booster doses should be available by late summer, early fall, probably, if we need them. Okay, there's no way of knowing whether we're going to need them just at the moment, but they will be available, and they're definitely on the table for the fall.
And so a couple more questions for you, Allison. Colleen Chung has asked, can we recommend mRNA vaccine to first trimester pregnant patients, or is it still preferred to wait until the 2nd or 3rd trimester?
To me, that's an individual decision. The only reason that there are 2 reasons why you might want to vaccinate later. The first is that vaccination in first trimester puts you at risk of there being a miscarriage that might be thought to be associated with vaccine. No evidence at all to think it will happen, but when things are temporally associated, it's really hard to get people not to worry about it, even if they know it's not true. So that's the only reason to avoid first trimester vaccination. the other potential thing is that it may be true that vaccinating in second trimester will result in higher antibody levels in the baby when the baby is born and better protection in the first few months of life. But the truth is that COVID-19 is generally not severe at all in neonates. So I think on balance, in women in hotspot areas who want to be vaccinated in first trimester, as long as they're clear about what the risk is of misassociating vaccination and miscarriage, there's no reason to avoid vaccination in the first trimester particularly.
Okay, and then I'm going to ask you to just comment on something you typed an answer to, but it's something that others might be interested in as well. So I think Vincent Lamb asked, can someone comment on inhaled budesonide as treatment for COVID in the first week after positivity? Are you able to just comment on that and maybe explain a little background on that as well for folks?
Yeah, so there's a trial published last month from the UK looking at inhaled steroids in people up to 7 days after the onset of symptoms, so twice a day inhaled budesonide to see if it would avert hospitalization, and it looks like it does. I think people's cautionary tale about it is we've seen a lot of initial small trials of things that looked really promising for COVID that have just bombed when they've gone into bigger trials. And the thing in favor of budesonide is that on the scale of adverse events, okay, inhaled budesonide is pretty low, and that makes it, I think, a much, people may be much more likely to use it in the setting where we don't have data. But I apologize. I actually think that needs to go to somebody. I've been spending all my time on vaccines, and I think my message to Vincent was that really we ought to ask Andrew Morris or the people who are working on therapy, because I'm probably not as up to date as I should be.
You know, Tara, I can, weirdly enough, the hematologist actually has something to say about
it.
So Andrew and I co-chair the Science Tables Clinical Practice Working Group. We actually have a science brief coming out in about 4 days to summarize the evidence on this, which is quite minimal, and to sort of give people some options for higher risk folks. They might want to use it on. The evidence is really, really poor, but we appreciate that there's few options. I can't even believe I'm answering this question, so I'm going to stop. But stay tuned, and I'll circulate that to you all if you'd like to send to membership.
That's super helpful. And David, go ahead.
I just want to highlight, because if people do decide to use it, I think it's really important, especially with this wave, we're seeing people around, day 7 and day 8, day 9, 10, they're initially getting better and then they crash. And so I think that we have to make sure that if we are monitoring patients, and we'll talk hopefully in a few moments about COVID at home, if you've given them budesonide, they still need very, very close follow-up, because it's not going to get them out of the woods. And we definitely know that there are people who've gotten budesonide who've ended up in the ICU. So it's not a panacea. I posted the study, only had 146 patients, the study in the Lancet. And the important takeaway is, if you're going to do it, you still need very, very close monitoring these people. If they're sick enough to need it, you may want to think about actually making a phone call to them twice a day.
Thanks so much, David. I'm just going to maybe actually change gears and have you answer a couple of questions, David. I know, and then give us a primary care update. So, I mean, I think you've answered a couple of these sort of in typing. People seem to, be worried about the second dose again. So, who's going to be giving the second dose? Is it the same organization, or is it a different organization? Are we going to get forgotten about? I personally hear this question a lot from patients. I went and I got my first dose. I didn't get a slip for my second dose. What's going to happen? Yeah. Maybe you can speak to that.
Yeah, sure. So I think that's actually part of what's been so confusing is early on, and by early on, I mean maybe it stopped about 2 or 3 or 4 weeks ago. A lot of folks, when they got their first dose, especially at a number of the clinics in the GTA, actually were booked for a second dose that day. And I think most of the clinics have stopped doing that now, partly because we don't know what the volumes look like. So even if the clinics, and the expectation is that people should be able to go back to the same place where they got a first dose, but the shipments change, right? And so because the shipments change, deciding that somebody may be able to come in on July 31st at 1 o'clock in the afternoon, there may not be a slot at 1:30 in the afternoon because there may not be enough vaccine at that site, for instance. So people are going to need to rebook a second dose. Organizations will be reaching out to patients through their booking software. I know the pharmacies, it's going to be quite a headache for the thousands and thousands of people that got it through individual pharmacies. But the expectation is that people should be able to go back to where they got their first dose to get their second dose. That being said, we have a provincial registry, and if somebody gets a dose anywhere else, then that's fine too, because it's going to be picked up in COVAX Ontario. So.
Thanks, David. So I'm just going to ask Brian to bring up the slides called Primary Care Cumulative. And I'm just wondering, David, if you could just give us a bit of an update on where
sure.
we're at with actually rolling out AstraZeneca. So we've had lots of discussion about AstraZeneca compared to mRNA. We've, of course, been giving AstraZeneca, and also where we're at, we're not just giving AstraZeneca, some have done others too. So where are we at in terms of primary care clinics providing vaccine?
So I should, really preface this by saying that family doctors in Ontario have been giving vaccine in probably every possible setting since the last week in December. And so that was long-term care and then retirement homes and doing home visits with Mrna or AstraZeneca, working in mass clinics, in mini mass clinics. I had colleagues that were vaccinating people in a community center last night up till probably after 1 a.m. And so, family medicine has really been one of the backbones of this vaccine delivery service. As many of you know, in March, I guess it was, we first were able to get vaccine in our office, and that was Covishield and AstraZeneca. This is the cumulative slide by public health region, including Pfizer and Moderna that was done in a primary care setting. So this doesn't include, obviously, the tens of thousands of hours that we've all worked in vaccine clinics or in other settings. This is just office-based administration. And so you can see the initial 6 public health units that gave 31,000 plus doses of Covishield, and now 85,000 doses of AstraZeneca. And then if you go to the next slide, this, I think, is a good news slide. So a week ago, this was at 30% of the doses were used. And so every weekend, because many of our colleagues are running clinics on the weekends, so that doesn't interfere with their day-to-day operations, we went from 30% to 60%. And I know that as of last night, in 26 out of 34 public health units, the primary care practices have said that they will be fully have administered every dose that was allocated to them. The other thing is that whatever the allocation was, which was 139, almost 140,000 doses, basically everybody's getting 11 doses per 10 dose vial. And so there's actually another 10% that's been administered. And that's why you see, in Algoma, in the first line, there's 110%. They administered 330 doses from the 300 doses they were given. There is going to be a bit of a redistribution, at least in Toronto, mostly because so many people have access to an mRNA vaccine. And so because so much of Toronto and Peel are hotspots and people 18 plus can get an mRNA vaccine, there's probably somewhere around, as of last night, about 1,500 to 1,800 doses that we'll be sending out of Toronto to other units where there is still very, very strong demand for AstraZeneca in the 40 plus age group, because they actually don't have access to an mRNA vaccine. Because of, as many of you know, 50% of the additional doses of mRNA vaccines for the next 2 weeks were sent to just to hotspots. So I think this is a great news story. It's just another distribution channel that we've all been working in to make our lives a lot safer and save lives.
Kara,
Thanks so much, David.
I just wondered if I could add something to what David just said. So because I would think this slide, David, is from the 61%, probably is higher given we're.
Yeah, this was from the third at night. Yeah.
And certainly what we're seeing is that the weekend and the evenings are, we get these bumps up in primary care. So I have no, and family doc's office, I have no worries that we're going to hit that 100% like we did with the first allocation. And we sent out a little survey in our last blast to members and just wanted to reflect back what we were hearing. First of all, to David's point about how much work people are doing vaccinating in so many different ways when they aren't able to get it in their offices, and really the deep desire to be able to give it in practices was something we consistently heard. I would say of those who weren't vaccinating in their office at this point, we had about a solid third of people who answered our survey saying we still, despite what we know about the challenges, and I can tell you that people like David and myself are fighting at every turn to manage those challenges, COVAX and administrative burden and some of these other pieces you all know so well. A solid third said, please bring it to us. So we hear you. My hope is we could start to see not just AstraZeneca, but Mrna, which is a lot easier than Pfizer to use in our offices. And so, I'm hopeful. We know that's happened in a few public health units and has gone really well. I think the other thing we're looking at is, could there be sort of two parallel tracks, these kind of larger primary care practices, or perhaps ones where they're tied with a hospital or with an OHT that could be more like hubs. That could start to, continue to give some of these vaccines, and at the same time trying to ensure we find ways for those who want to have these vaccines in their office to have them. It's, I will say the 34 public health units makes this a challenge, and many of you on the line who are from certain regions where, it's working better than others. I can't deny that that's a problem. It means we continue to shine the light on those public health units where it's working really well, and encouraging the sharing of those practices and across the other regions. But that is a barrier, and it makes it complicated for sure. So, but I'm hopeful, right, Liz?
Active discussions about Mrna, getting it into primary care offices, and especially, we know there are a number of places in the province where in the over 70-year-old population, that upwards of 30% of them are still not vaccinated, and we're going to have a real role in making sure that those patients that are over 70 that are our patients, they're going to have a discussion with us, and hopefully we're going to get them vaccinated. We hope that within the next month, and I can't guarantee a date, that we'll be able to be sending lists of non-vaccinated patients to primary care providers. So these are all your patients, Dr. Smith, who have not yet been vaccinated for COVID-19, who are over 70, who are over 80. So we can do targeted outreach. More to come.
Yeah. Thank you so much, Liz and David, for your ongoing advocacy. We all know on the call how important it is for family doctors to give vaccines in our clinic to some of our patients who won't go elsewhere. In addition to all of the great other things we're doing, we know that we can make a contribution there. So thank you. I'm going to turn it over now to Allison McGeer, who's going to give us a little walkthrough more on the variants. We'll go to the next slide, and Allison, over to you.
Thanks very much. This slide is here for two reasons, partly because if you just need a little lightening of your day, KXFD has some nice kind of science math COVID jokes, but really just to point out that I don't want to defend our vaccine rollout as efficient or optimal or organized or equitable, but it is working. Okay, we're above, at some level, we're above, as of yesterday, 43% of adults in Ontario with at least one dose of a COVID vaccine. So it's I think really important in the chaos to hold on to the good things, and this is a very good thing. We're making progress. Now, there've been a lot of questions about variants, and I thought it might be helpful for people to have a little bit of biochemistry background about how we name variants and what they look like and how we diagnose them. But the most important message about variants is they don't change anything clinically. When they first appeared, we thought that we might manage contacts or cases differently if there were variants. And the answer is probably we shouldn't be doing that. So if you're primarily concerned about how you're managing cases, this would be a good time to answer the emails you have to, or to just take a 5-minute nap while we talk about how we name variants. And then we'll get back to the important implications of variants, which is about what they might tell us about vaccine use, and then a little bit about J&J vaccine. Okay, can I change slides here, or are you changing slides? Here, good. Okay, so beginning of time, first year biochemistry, right? All of the information in DNA and RNA is encoded in 4 base pairs, okay? Adenine, cytosine, thymidine, guanidine. And how you make proteins with the 21 amino acids that there are depends on the organization of the order of those bases into 3 base combinations, okay? 3 bases of DNA or RNA is a codon, and when you translate that into protein, the codon gives you the amino acids you're going to have. So if you're translating an mRNA that is AUG, it turns into methionine. And so you build long chains of amino acids that turn into proteins by linking up amino acids one at a time. And amino acids have 3-letter codes and single-letter codes. And now we're talking about genomics. We use single-letter codes to identify amino acids, which is a little irritating because they don't actually match the amino acids very well. Next slide. So if you look at the spike protein of the different variants of COVID, the spike protein is 1,273 amino acids. So that's 3,800 bases and 1,273 codons. And if we just think for a moment about how we're identifying the United Kingdom strain, we identify it because it has a mutation at position 501 on that 1,273 codon or amino acid chain. You'll see that what happens with proteins, right, is that you make them in this long chain and then they fold. And they fold because amino acids have different positive and negative charges, and they fold into these really complicated structures when they do that. So what you see on the screen is what the folding of a spike protein looks like. And at 501, the mutation is N501Y. And what that means, if you look in the little blue circles, is that at one position in the RNA, there's a substitution of thymidine for adenine. And that means that the amino acid changes from asparagine to tyrosine, and that changes the charge in that position, which changes the shape of the protein in the receptor binding domain, which is this green part, okay? And then you can see that that change in the receptor binding domain makes a difference to how well it binds to the epithelial cells, and as it turns out, contributes to, higher risk of infection, more severe infection. South Africa variant has actually 2 mutations in the RBD section, 501 and 484. So at position 484, it's an E to K, which is a glutamic acid to lysine. Okay, so when viruses replicate themselves, they make mistakes in which base they put at each position. And mostly those mistakes are either not important or they result in a virus that's dead. But every once in a while, they result in a change that improves the virus's ability to do something it wants to do. Okay, bind to cells, replicate faster, long list of things. Okay, so any virus can mutate fairly rapidly and change. Think HIV, okay, against vaccines, think influenza. Now, we tend to think that mutations in the receptor binding domain are going to be the most important. But in truth, next slide, The spike protein of COVID actually does calisthenics, okay? So under normal circumstances, it's a trimer. So it's 3 of those spike protein sequences put together, make one spike on the surface of a coronavirus. And in normal circumstances, it sits like the 2 at the left that are closed. If it wants to bind the cell, it opens up like a flower. So it exposes the receptor binding domain. Once it's bound to the cell, it does this long stretch, and then it folds itself over so that it brings the surface of the virus to the surface of the cell and lets the virion in. So you can appreciate that it doesn't much matter where you change the shape of this protein. It has the potential to affect how this protein works and how it binds to the virus. And in fact, mutations in other proteins in the virus can also make significant differences. Next slide. So when we get to variants of the virus, they're not just 1 mutation or 2 mutations usually. They're a virus that has accumulated a series of mutations that give it an advantage over other viruses. They allow it to spread faster, replicate faster, and take over from other viruses. So what we saw in Ontario, which is everything was Wuhan or D641G up until January, and then slowly B117 just spread faster than the old variant and took over everything. So the 3 variants that we're looking at now all have 501Y mutations. Obviously, that's an important mutation in terms of improving virus survival, but they have different numbers of total mutations. And if you look at the details here in numbers, all of them have somewhat different mutations. The Indian variant doesn't have a 501Y mutation, okay? It's got other mutations throughout, and it's really hard to tell at the moment how successful it's going to be and whether it makes a difference. So it's not necessarily true that all bad variants coming down the road are going to have 501Y or this selection of mutations. Next slide. Okay. So now let's talk about how we detect and look for new mutations. When you test for COVID in a regular lab anywhere in the world, you're doing testing to ask whether a particular sequence, something usually about 100 base pairs long, in one of that codes for one of the SARS-CoV-2 proteins. Can be any number of them. Some of them do nucleocapsids, some of them do open reading frames, some of them do spike. Different companies, different labs use different sequences. And it's a really small section of DNA, so there's not likely to be a mutation in it, right? So you think about 100 base pairs is 100 out of 3,800 in spike and a whole mess of other proteins. So all we're doing when we test for COVID is looking for that specific sequence in COVID and saying yes or no. If you want to know whether the variant is there, you actually have to sequence the entire genome so you can ask whether the specific 17 or 19 or 23 mutations are there. Difficult, expensive, and takes time. But we want to know quickly about what's going on with variants in the province. So the way we do that is we've developed a new PCR testing, which looks at much shorter stretches of the RNA that just tells you whether there's been a change at particular sites in the RNA. So now in Ontario, you do PCR testing, you get a yes, no on COVID, and then you do a PCR that tells you whether there's been a change in 501 and a PCR that tells you whether there's a change in 484. And then you get a report a day later that says, has a 501Y mutation. Okay, that's probably one of the 3 variants, or has both mutations. That's either P1 or B351. And then you have to wait for the sequencing to tell you which it is. It takes a long time. And of course, you don't detect new variants. So in the background, Public Health Ontario is running sequencing on about 5% of all isolates. You just can't do all of them. And that background sequencing is intended to make sure that if a new variant emerges in Ontario, God save us, we'll find out about it, okay? And as we get imports of new variants, we'll be able to identify them. So you saw a couple of weeks ago when the Indian variant was first identified, Immediately, Public Health Ontario went out and looked at all of their sequencing in Ontario, and they said, oh, look at that. Okay, we've had 25 or 30 of them. So that's going to be an ongoing thing. Every time a new variant is posted somewhere that people are worried about, people around the world will look at their sequences and ask whether anybody else has seen it and what it looks like, what it's doing. Next slide. Okay. Two questions you need to know about variants, whether they're more severe and whether they change the course of disease. That's one difficult question we're not going to talk about. Second difficult question is how well the vaccines work. And it's really frustrating to try to figure that out for a variety of reasons, okay? The first is that under normal circumstances, we've had a disease around for long enough and vaccines around for long enough, you have some measure that tells you whether a person is protected or not. Sometimes it's just you've had 2 doses of vaccine. Sometimes it's you have a certain level of antibody, but we're not there yet with COVID. Okay, so there's no way of predicting accurately for anything whether an individual is protected or not. When we're measuring protection, we want to know protection from asymptomatic infection, from risk of transmission to other people, from illness, from hospitalization, from death. Those all might be different with different variants, right? So you might have a vaccine that reduces your severity of illness, but doesn't prevent transmission all that well. Those are important things, but they're different and they're all hard to measure. You look at the studies on the next slide, even big studies of vaccine have confidence limits on the efficacy that can overlap, and you're just stuck. You can't tell whether things are different often. And finally, you look at what's happening in India, variants appear in countries that may not have the infrastructure to do assessments rapidly. And if only 5 or 6 countries that are all low and middle income countries have a variant, it's going to be really hard to get data. Honestly, it's really hard to get data in Ontario, okay, about what's going on, never mind in countries that have less ability to deal with it. Next slide. So then lastly, what do we know about protection against variants? And I think there's now complete confidence that B117 is fine with our current vaccines. There may be a little bit less protection, but it's not significant and we don't need to worry about it. B351 is different, okay? It really does look like there's some drop in efficacy. It does not look huge. The vaccines are still going to be effective against B351, and there's 2 new papers this week about it and an old one. So Qatar has, at the moment, is about 50% B351, 50% B117, and they've been using the Pfizer vaccine, and you can see that their analysis is that the Pfizer vaccine is significantly less effective against B351 than 117, but it's still a pretty efficacious vaccine. So probably it's something that we might want to talk about boosters for, but not a reason to worry about not getting the vaccine. The Jansen study in South Africa showed a vaccine efficacy of about 60% against B351 in HIV negative people. So that compares, if you have looked at the FDA data, the other new data on Jansen, to about 66% in their overall estimate. Really doesn't look like it's different, but if you look at the ends of the confidence limits, it could be a drop as much as Pfizer, could be less than that. The South African study is with AstraZeneca is the one that everyone's worried about. Okay, in that study, the vaccine was actually not significantly efficacious against B351, but that study was in a really low risk population. Okay, they had, I think, a total of 10 patients in the entire trial that had fever for more than 48 hours. And their upper limit of efficacy is 55%. So, I think when you look at that, you walk away with, it's really looking like B351 vaccines are not quite as effective against B351 as against other vaccines. Not enough yet that we should differentiate between them, or that we should say, well, it's not going to protect us from B351, so we don't need to vaccinate. But enough that you can see why people are talking about boosters that have B351 in them, so that we get optimal protection from vaccines. And the P1 and Indian variant, we just don't have data on. We have in vitro data that suggests that neutralizing antibodies for P1 go down a little bit less than B351, which is why the new vaccines have B351 in them as opposed to P1. So it's probably going to be somewhere between B117 and P1, but we really don't know yet. And for the Indian variant, unless somebody in the chat has data that I haven't found yet, we just don't know. We don't have data yet. So lastly, the question is, what's happening with Janssen vaccine? To my knowledge, our 300,000 doses of Janssen vaccine for Canada are still being held at Health Canada because of quality issues potential quality issues. Okay, I don't want to overstate it, but worries about the production facility in the United States. Don't know how long that's going to take to solve or when they're coming. Vaccine efficacy with one dose of Janssen is, as I said, in the clinical trial, about 66%. It is, I think, not possible to, there's two ways of looking at that. One is a single dose of Janssen is the same as a single dose of anything else, and we're actually going to need a second dose of Janssen. And the second is the Janssen vaccine is manufactured to give you longer protection with the first dose, which might be true. So we're still a bit on the fence about whether you're going to need a second dose of Janssen vaccine. Thanks.
Thank you so much, Allison. That was a tour de force deep dive into variants, and I think all of our attendees really appreciated it. I think for many, it took them back to their undergrad days. Some people said that your explanation reminded them they needed to do some yoga. So, but everyone, I think, really, loved it because it gave us that really deep understanding. I see that we actually are at time, and I apologize that we're not going to be able to get to more questions this week, but we'll be back again in 2 weeks. Next slide. I do just want to let David Kaplan just speak briefly around COVID at home.
Yeah, very kind. Thank you. So to date, we've sent out well over 6,000 O2 sat monitors. I think we've monitored over 10,000 patients in the province at home, which is amazing, all of you. For practices that want to be part of this, we'll post the link in the chat. We'll send it out with the on the website with the recording, but the monitors are free of charge through the Ministry of Health. The pathway is available, and in fact, we're about to release or already have released a pathway to help discharge patients earlier from hospital so that we can actually wean them off their oxygen instead of using an acute care bed, wean them at home with the help of respiratory therapists. So amazing work that primary care is doing across the province to keep patients safe and now to actually increase hospital capacity so we can get our system back online.
Thank you, David. Yeah, we've been doing so much. All of you have been doing so much to really help us deal with what's been an awful year. And thank you for your ongoing efforts, from vaccinating in so many different settings to caring for sick patients and then caring for everyone else as well. Just a reminder, we're going to be back in 2 weeks. So May 21st, we'll send out information on that in the next few days. We'll have our slides up as usual, along with the recording of the talk and a summary of some of the Q&A on the website there. Please do fill out your evaluation. You'll get emailed that shortly. We do appreciate your feedback on who we should have back. I've already seen some comments on the chat that people loved hearing from Dr. McGeer and Dr. Pai. And I just wanted to thank those two special guests for their work today. Thanks to David, Liz, and the back team who make this happen. And again, thanks to all of you for all of the work you're doing supporting patients in our communities. Take care.